We really want, we couldn't think of anyone else when we were planning this series. So it's like a privilege to introduce you to this program. Professor Miriam is a professor in medicine, palliative medicine in Hull York Medical School, and she's the director of Wolfson Palliative Care Research Center at University of Hull, England. And I think more than that, if you search any articles or publications on chronic breathlessness syndrome, I think it's just Dr. Miriam's name that comes, and we all have read and still reads a lot about it. Thank you to Professor Miriam for finding time to be with us for this program. Thank you so much for accepting our invitation.
Very nice to be invited. I'm going to attempt to screen share. So I'm never particularly good at this, but here we go. And let's see where that takes us. Let's see if I can put it on slideshow from the beginning. Right, I hope that's all right. Sridevi, can you tell me if that's okay?
Yes.
So what I'm going to do today is talk through palliation of respiratory symptoms. And I just want to start by saying that this picture on the right is part of a breathlessness exhibition that one of my postdocs, Anne Hutchinson, has developed in conjunction with local patient and carer groups, local artists and sound recording artists, just to try and depict the experience of living with chronic breathlessness. So this is one of the pictures that you can find on the exhibition on our website. The stairs scare me, something that we do every day without thinking about it. If you're living with chronic breathlessness, stairs become like Everest. So we're going to talk a bit about what we mean about chronic breathlessness syndrome, what's the biological rationale for issues around management of chronic breathlessness. I'm going to talk to you about the breathing, thinking, functioning clinical framework as a way of helping us in the clinic to work with our patients and improve their symptom, and then finish up with just a couple of slides on management of chronic cough. So, chronic or persistent breathlessness syndrome. The term persistent is one that's better used with patients, because I don't know about your patients, but ours, if you say chronic to one of our patients, they think you mean really, really, really severe, rather than just something which has been going on for a length of time and is just still there. So the definition that we came up with an international consensus was that breathlessness that persists despite optimal treatment of the underlying disease, and that results in disability. And I thought you might be interested to see this rather lovely study that Sunita Daniel did with one of my medical students at the time, actually, or she might just have been a junior doctor by then, where there's focus groups with 15 physicians from oncology, palliative care, cardiology, and respiratory in Kerala state, and asking them about chronic breathlessness, and did they see it? What did they do about it? How did they feel about it? And their findings were that these physicians agreed that this was a really prevalent issue and concern with a major impact on families, patients, and physicians. They described feeling incredibly helpless, of seeing the distress, but then not knowing how to manage it. And in fact, they had enough insight and honesty, I would say. I really took my hat off to these physicians for being so honest, that because of the distress it engendered in them, because they felt they couldn't help these people, they then actually avoided it. So they actually avoided asking patients about their breathlessness. And they also felt that they had a lack of access to palliative care, which they felt might have helped. And because of this, because they didn't then ask about the chronic breathlessness, patients then don't tell people about chronic breathlessness because they think, well, if there's something that could be done, they will be asking me. This all contributes to the breathlessness being invisible to the clinical services. And here are some quotes from these doctors. We're very sensitive to a person's pain, but we don't understand dyspnea. Or we tend to underestimate the presence of breathlessness. It's very difficult for the bystanders also who are along with them to cope with the stress. And these patients are already breathless patients, so actually we'll try and ignore them whether the breathlessness is increasing or decreasing. I give that doctor 10 points for honesty. Chronic breathlessness, what do we mean by it's invisible? Why is this a problem that it's invisible? It's because there are evidence-based interventions targeting at the breathlessness itself that could help these patients. So should be up to us to measure and assess in every patient. We shouldn't expect the patient somehow knows there are things that can be done, because patients just assume this is normal, I'm bound to be breathless with my COPD, I'm getting older, I'm losing weight, or whatever it is. And again, if it was important, if something could be done, my doctor would be asking me about it. And as we've just seen, doctors are not asking them about it because they don't know what to do about it. We should be measuring and assessing. We should be actively identifying. And we shouldn't wait until it's a physical sign. We should be asking for the symptom. Because even when breathlessness is really quite severe, if a patient is sitting down in the consultation or on their bed in the ward, you may not notice that they're actually quite breathless the minute they try and do anything. And we make it normal. We think of it as, well, they're COPD, they're going to be breathless. Of course they're breathless. If we don't actively elicit it, it's unlikely that the patient will tell us the full extent to what is going on. And there are things that can help. So this is quite old now. This is 2007, but I still think it is very useful to think about, well, how do we manage breathlessness? So the first step is obviously to optimize the treatment of the underlying disease. And it's amazing how often this is not the case. Partly because, again, as a clinical profession, we tend to just see the first diagnosis. We'll maybe see COPD, but then we forget they have heart failure, or we'll see the heart failure and we forget they have the COPD. And so we'll optimize treatment for one, but we'll not check that they're optimized for another. We'll not check other things like, have they become anemic? Have they developed other disabilities and diseases like hypothyroidism? I mean, when was the last time someone sat back and said, are all this person's conditions optimized? Second step, if you take nothing else from this talk, be repeating to yourself non-pharmacological, non-pharmacological, non-pharmacological interventions for breathlessness, because there is a good evidence base. We like to think we know about pulmonary rehabilitation. Yes, we know it works. It's got a really good effect size. How often do you actively prescribe this, encourage this, repeatedly suggest to them and support your patients to go to pulmonary rehabilitation? How many times do you go to your clinical service leads and say, we do not have enough pulmonary rehabilitation in our hospital or in our community service? If, as doctors, you do not actively support pulmonary rehabilitation, patients will think it's not important because it is not a prescription pad. So absolutely support your patients to go to pulmonary rehab. And in doing so, you'll have to actually help them up front about how they manage their breathlessness, because we know that people who have more severe breathlessness are less likely to go to pulmonary rehab. And if they do go, they're less likely to complete the course. Because if you go to pulmonary rehab and nobody tells you how to manage your breathlessness, the minute anyone gets you moving in pulmonary rehab, you think, that's not nice, not doing this, thank you. Likewise, exercise. How many times do we really get patients to look at their physical activity? Do we do that as in our clinical practice? And it can be done very easily. I mean, I used to incorporate simple sit to stands, just getting patients to stand and sit, practicing their quads exercise as a beginner in my clinic. It can be done in 2 or 3 minutes. For those for whom anxiety and a real emotional response is very much part of the breathlessness, cognitive behavioral therapy got a good evidence base behind it. Do you know if there is any way you can refer to that in your own locality? Do you know? Have you found out? And if you haven't, then are you making any noise to say, we need this support for my patients? The simple handheld fan. I know that not just in Indian culture, but in British culture, particularly amongst the elderly, there's this sort of abiding fear of the draft. My grandmother used to be horrified at the thought of a draft. You'll catch your death of cold with a draft, and here I am wanting to wave cool air over somebody's face. But we an evidence base coming around the use of cool airflow to help manage breathlessness. Pacing, prioritizing. Don't rush at something, but just like the old parable of the fable of the tortoise moving slowly and the hare making a rush for it and then having to recover, and the tortoise then beats them. Pacing, prioritizing gets the job done. anxiety management, relaxation, pursed lip breathing, particularly in COPD, to increase that positive end expiratory pressure and to prolong the out breath and to help prevent air trapping. Diaphragmatic breathing to maximize use of the lung volume that people have access to. Education and support for family carers. How do you routinely involve the family carers in talking to them about the breathlessness and how they can help manage it? Do they have a crisis plan in place so that the next time things are starting to wind up, they understand the importance of the relaxation, the breathing regulation, and the handheld fan to try and avoid a crisis admission? And then, and only then, in people who still have severe breathlessness, will we consider pharmacological interventions. So, a biological rationale. There's lots of lovely arrows going everywhere. I'll talk you through it. So, we call this the mismatch model, and it was first mooted in 1991, and it's as good as any to try and explain what's going on with people being breathless. So, the brainstem respiratory complex takes in messages from central and peripheral chemoreceptors. It also takes in messages from the association cortex of thoughts and past experiences. It takes in messages from the motor cortex. It takes in messages from the limbic system and your emotions. And it computes all of this and says, in order to be comfortable, I need the body to ventilate this much. And it sends that copy of that, sends a message direction to the respiratory muscles and an efferent copy to the sensory cortex. So the sensory cortex can match what the body should be doing with what the body is actually doing. And if it matches, we are comfortable. So if you were to swim underwater, when you come out, you will be appearing to be very breathless, but actually you're quite comfortable because you're only breathing in response to the drive that you've been told to do. It becomes uncomfortable halfway through underwater where you can't breathe because you get a lung full of water. So the mismatch gets bigger and bigger as you swim underwater. The minute you're out and your ventilatory response can obey what your brain is telling you to do, you're then comfortable. So what we're doing in breathlessness management is trying to manipulate this system so that mismatch is reduced. I'd also like to say to you that chronic breathlessness is different to acute breathlessness in somebody who is otherwise healthy. Because people with chronic breathlessness experience and process that experience of breathlessness in the context of what has happened before. And we know from the work that the team in Oxford have been doing with their functional MRI scanning is that the brain creates expectations and beliefs, so-called psychological priors, based on previous experience. And that influences the incoming breathlessness sensation. So if somebody has been terrified and thought they were going to die with breathlessness, then the next time they do that, whatever it was that triggered it, they're going to expect to be that bad. People living with chronic breathlessness process the sensation of breathlessness involving the frontal association cortex in the context of memory and fear. Healthy volunteers do not. So this work has come from functional MRI scanning of the brains of people with acute induced breathlessness in healthy volunteers and in people about to start pulmonary rehab in people living with COPD. And the same breathlessness challenge you can see is processed differently in the brains depending on whether people have been living with breathlessness or not. And then interventions such as pulmonary rehabilitation show a corresponding reduction in the frontal association cortical activity in people living with COPD. So it shows you can modify these incoming sensations. And the other thing that the neuroimaging team have found is that opioids, at least they've done a study with just a stat dose of opioids, seem to suppress the conditioned anticipatory brain responses to breathlessness. So complex interventions. Pulmonary rehab, we've talked about. Here's some of your evidence base. Breathlessness intervention services. So this is more traditionally in the advanced disease space, often run by palliative care services, so less emphasis on aerobic exercise, but many of these non-pharmacological techniques involved in breathlessness management. These are effective. Notes, as I've said, breathlessness is a barrier to attendance and completion of pulmonary rehab, and so this needs to be addressed upfront. However, people with moderate to severe breathlessness can have good improvements with pulmonary rehab. So, as I say, this should be addressed upfront to encourage them to go. The doctor should prescribe and strongly endorse non-pharmacological interventions. The physiotherapist, occupational therapist, and nurse are crucial, but the doctor should also be familiar with and introduce these interventions to the patient. So on to the breathing, thinking, functioning model. So this recognizes, this is a clinical framework to help us think about all the different aspects that's driving the breathlessness for an individual patient. And it recognizes at least 3 vicious cycles. So thinking, we've talked about memories of past experiences, anxieties. What does this mean? The more anxious somebody gets, the more breathless they are. The more breathless they are, the more anxious they are. So you can see that there is a vicious cycle winding up that breathlessness. We also know there's a functioning vicious cycle. So if somebody has breathlessness on exertion, they'll think, I'm not going to do that exertion. So they do reduced activity. They become socially isolated, they become reliant on help, and their muscles and cardiovascular systems become deconditioned. And the more deconditioned people are, the more breathless they get for any given amount of work. And so the deconditioning cycle, the functioning cycle, again, increases and winds up that breathlessness. We then look at the breathing vicious cycle. And you'd have seen people with dysfunctional patterns of breathing. And if all you want to do is to get the breath in because you're breathless, you breathe in, and you breathe in, actually it's excruciating because all you end up is with massive air trapping. What we need to try and get people to do is to have the long out breath, empty the lungs, and then the next breath in can be much more effective and much more satisfying. So techniques then that can try and tackle some of those these vicious cycles. So thinking about interventions we can teach patients for the breathing vicious cycle. So the pursed lip expiration, rectangle breathing. So we tell sweet people, right, look around you. Okay, there's a door over there, and I want you to let your eyes follow the long end of the door as you breathe out. And then when you breathe in, follow the short bit, then back up again on the long bit, so that you're trying to get them to re-regulate their breathing pattern to allow the breath to come out before you start putting the breath in. Because one of the sensations that modifies our need to breathe is respiratory wall movement. Now, if you've managed to get your lungs so full of and trapped of hyperinflated air, your chest wall moves nowhere. So that is going to be sending signals to your brain, this person's not breathing, I'm not breathing, I'm not breathing. So first get them to empty their lungs, and therefore their chest wall will move better when they then fill it. This also reduces respiratory rate, it reduces dead space breathing, and it reduces dynamic hyperinflation. And as I say, it allows better chest wall and lung tissue movement, which all helps modulate that urge to breathe. It can be done as part of yoga or Tai Chi, depending on what people might like. And it can be used in conjunction with a handheld fan, giving cool airflow at the same time. So when I used to be teaching patients, I'd get them to hold it in front of them with a nice prop position, so a good steady position for them to have good chest wall movement, and tell them to blow out slowly into the middle of the fan and then let that fan push the air back into their lungs, using language that the patient might recognize. And certainly in Marchetti's study with COPD, he found that actually in the fan group, it reduced hyperinflation by facilitating, I presume, a long out breath and increasing inspiratory capacity. So this is a study that we did with magneto and cephalographic scanning. It's a very long word to say. And what we did was that we put people with advanced COPD or asthma, a range of pulmonary conditions, but all with MMRC 3 or 4 breathlessness in the scanner, and we got them to exercise to maximum toleration, sat in the chair. We then scanned their brains during recovery under two conditions, one just in room air and the other with cool air flowing across the front of their face. And this picture just shows you that the cool air during recovery, you can see different brain patterns. We're modulating their sensation of breathlessness with that cool facial air. And in fact, the patients would say things, oh, that feels lovely. Almost, and this was picked up by the French group who said, actually, they're probably acting as a neural respiratory gate. You know, like we talk about the pain gate. So you hurt yourself, you rub it, And so you gate the painful sensation by the more pleasant sensation of rubbing. So we may be gating the unpleasant breathlessness sensations with the pleasant sensation of cool airflow. This particular scan was looking at alpha waves, which is also our sensory refocusing. So it's helping them to focus on a pleasant sensation and away from the unpleasant sensation. So this isn't just distraction, it's not just placebo. It looks like there are central mechanisms to explain why cool facial airflow can help people manage their breathing. We also looked at the literature. We looked at 16 studies. This was of which 11 were randomized controlled trials of oxygen versus medical air, 4 trials of a fan control and a fan cohort study. And we looked at, we didn't look at the oxygen arm. We wanted to look to see what happened in people before and after with medical air or fan. And this is what we found. So there were 3 studies with the fan at rest. And you can see on the meta-analysis, you can see the little black diamond clearly favoring exposure to the fan compared with fan to leg. We then had 2 studies where airflow delivered as medical air in advanced cancer patients at rest. You can see again, the little black diamond favors exposure over no exposure. And if you looked at, we had another 2 studies where these are people completing pulmonary rehab. Again, just room air, not oxygenated medical air, just the flow of air across the face and nasal mucosa gave benefit for breathlessness. And then there's been a systematic review published in 2019 with 9 randomized controlled trials of the fan, cohort study with the fan. 6 of the trials reported a significant improvement. There were 3 that found no difference, but none of these 3 were designed with sufficient statistical power. So it's not surprising that they didn't find a difference and they weren't designed to do so. We talk to people, they will tell you. And we did a mixed method. We had 133 interviews where patients were talking about the treatments they got for breathlessness, and 82% perceived some or substantial benefit from the handheld fan. And here are some quotes. Well, I used to use Ventolin, so that's our trade name for beta-2 agonist, SABA. Used to use Ventolin up to 30 times a day. Now I don't use it at all now. The best things where it worked had a positive effect on my condition, and now I've resumed cooking. A much quicker recovery than I used to. Now, this latter point is very interesting because if you can support people to say, look, yes, I want you to move. Moving is going to make you breathless, but here's a fan because it will help you recover from breathlessness more quickly. They're more likely to do some more exercise, and we want them to exercise because exercise is good for the muscle conditioning, and if their muscle conditioning is good, their breathlessness for any given amount of work will reduce. So that's the breathing cycle. What about the thinking cycle? And in this, I include emotion. What's going on up here? It's important that we understand the triggers, the context, and meaning of breathlessness, because if we don't understand that, we don't understand what's driving the distress that patients might come up with. If they've seen their father die horribly of lung cancer, the fact that they're now starting to become breathless might have significant meaning for them. Have we put in place a crisis plan, taking into account the huge role of panic and emotion in response to breathlessness? Have we taught them some simple relaxation anxiety interventions to help them get them back in control of their breathing pattern? Are they someone who might benefit from cognitive behavioral therapy, of challenging any abnormal interpretations they've put on? I'm feeling more breathless, therefore I'm going to die, is a common one. So interfering with that thinking and emotion cycle can be enormously effective. And then functioning, we want people to move. We want them to exercise. We want them to engage with their social life and their physical life. And we want them to be able to access clinical help and other sorts of help appropriately, rather than waiting until they are in a serious crisis. And so we want to move them from maladaptive coping ways of dealing with things like restricting their activity, cutting themselves off, feeling helpless, and I can't do anything about it myself, you've got to help me. And their role in life becoming smaller and smaller, through to adaptive, where we can encourage activity, we can get them back to moving, we can encourage them to maintain social contact and believe that they can take a certain amount of control over their own management. And that even if we can't maintain roles, we can modify them so that they still have a role to play in society. Remember the family carers. Involve them in education about and practice with the interventions, because otherwise, the minute they go home and they start doing some exercises, their family member is going to say, no, you sit there. Particularly for the older generation, where that's can be part, certainly in our culture, and I suspect you're not that different, can be part of respect. And it's actually about telling our elders, no, we really do need you to move. We want you to get out of that chair, and we want you to walk regularly. There is also a key role for the clinician here. And the work that Anne Hutchinson did with developing her concept of breathing space, which fits with this coping and help seeking enormously, is that where the clinician addressed the breathlessness in addition to the disease treatment, patients were able to live better with their breathlessness than when the clinician only focused on their FEV1 and their inhaler technique. Where the clinician understood the impact on their life and encouraged them to make interventions along the lines we've been talking about, patients were able to live well. So that's just a summary of what we've talked about: the breathing, thinking, functioning, vicious cycles of breathlessness, and how to wind them back down again. Pharmacological interventions. The only drug with particular evidence is low-dose morphine. A trial is ongoing at the moment with mirtazapine. So I'm just going to give you a quick whistle stop through the evidence that there is for morphine. We don't have the last answer about morphine. There is much we do not know. What do we know? Well, the strongest evidence in favor is in respiratory disease, and the review by Ekstrom and colleagues in 2015. Small studies, but nevertheless there they were. And one of the interesting things was that if you looked at across all studies, the benefit was kind of fair, really, wasn't massive. If you looked at studies where they reach steady state, so repeat steady dosing, not just one-off dosing, steady state dosing, the effect size was better. And that is one of the bits of evidence which is moving us to say, you either need to use sustained release preparations if you have access to them, or if you do not, you prescribe the Oromorph regularly. And it is not to be given to the patient as a bottle and say, take this when you need it. And it seems to work best when patients have a little dose, almost cloaking the brain, modifying that incoming signal of breathlessness round the clock, helping cope with all those little exertions, all those little exacerbations of breathlessness, and not waiting until, well, I'm feeling dreadful. And there's also an anxiety, I think, about sending people away with a bottle of Oromorph, take it when you need it. Well, they can end up taking a big dose if you do that. Whereas if you restrict it to a small dose around the clock, then I think that there is evidence here that that is your best way to affect and balancing risk. A systematic review in a range of diseases. Again, none of these studies were particularly big, but a clear meta-analysis in favor of morphine. That was back in 2017. Since then, there's been a couple other trials published with much larger sample sizes. There's this 7-day low-dose morphine versus placebo for chronic breathlessness published by David Currier and the Thorax in 2019. No benefit for their primary outcome of breathlessness now. However, there were some problems with the methodology that make interpretation difficult. Due to slow recruitment, they expanded their eligibility criteria to include patients who you wouldn't be using it clinically anyway. The breathlessness wasn't bad enough, so much less likely to see a benefit. And as I say, you wouldn't be using it in this group anyway. And secondly, there was no measure of physical activity, so you wouldn't notice if there was any improvement of exercise tolerance, because you could say you were able to do more, but your breathlessness was the same. And so we just don't know that from this trial. Also, immediate release morphine was available in both arms at the insistence of the ethics committee, and there was more use in the placebo arm. So did that affect the results? So there's questions about this study. The second study, published a year later, was Cindy Verbeck's trial along with Daisy Janssen's group in COPD. This was a 4-week study as opposed to a 7-day study. And they found that their primary outcome of the COPD assessment tool had a statistically significant improvement in the morphine group. They also included people with MMRC2, which is a bit surprising, again, because I don't think any of us would particularly be thinking of morphine in that group. But if they looked at the subgroup of people with MMRC3 and 4, there was a greater reduction in worse breathlessness over 24 hours in the morphine group. They found no particular excess serious harms, including respiratory harms. So what dose might you use if you try it? Well, the dose finding study we published back in 2011 looked at dose ranges between 10 and 30 milligrams a day. Each dose level was titrated for a week, and then they stayed on long-term on the dose of clinical benefit. And what was found was that approximately 2/3 benefited. So not everyone is going to be helped by morphine. It doesn't work for everybody. But in those who did, just over half of them improved with only 10 milligrams a day sustained release, and over 90% improved by 20 milligrams a day. So we're not talking big doses here, we're talking small doses. Safety, one of the best studies for this was looking at patients on long-term oxygen therapy. So this is very severe respiratory disease in a big Swedish national study. And at doses of 30 milligrams or less, there was no signal of either increased admission or mortality for people with opioids alone. And again, in lower doses with benzodiazepines, starting to creep into an issue with mortality. Again, this is an observational study, so we don't know if this is cause and effect. Maybe the people on higher doses were those who were more severely ill, and that is why they were dying, a signal of dying. But I think the take-home message, if the other study shows that if you're going to get a benefit, you get it before 30 milligrams anyway, then why would you want to push the dose up for the breathlessness and risk that this might be causal? In terms of safety, again, Daisy Janssen's group again looked at systematic review. And in the subgroup of people where there would be CO2 and oxygen levels measured, they found no clinically significant difference in people on opioids for breathlessness versus placebo. They did have some non-serious respiratory depression described in 4 patients, and in one patient, one case report, a cancer patient pre-treated with morphine, so already on morphine, then developed temporary respiratory support needs following a nebulized morphine dose for breathlessness. So all taken into account, that does not shout that the fears of respiratory harms are borne out in practice when the dose is responsible and it is monitored well. Morphine has a known safety profile, so therefore it should be prescribed for the right patient with due care and monitoring. And this is the same for any medication. We can kill people with beta blockers, ACE inhibitors, beta agonists, anti-diabetic medication, you name it. We can kill patients if we do not treat the right patient with any of the medication and we don't monitor them properly. The Australian Therapeutics Goods Administration has, in response to all these morphine evidence, has now licensed one of their preparations for use in chronic breathlessness, which is a world first. And it's interesting to look at the criteria that they have put against it. So maximum dose, 30 milligrams a day. This is a sustained release oral preparation they're using. And they said that in addition to the sustained release preparation, immediate release oral morphine solution should not be co-prescribed. And it should not be used for acute or acute on chronic breathlessness, and used with caution where renal function may change unpredictably or rapidly. So although this is only in Australia, I think these principles are useful for us to look at if we're considering prescribing opioids for our patients elsewhere in the world. So much of what I've said you can see here in this open access paper that I've given you the reference for here, so you can have a look at that. Other drugs, just to quickly nip through, there is no evidence for or against benzodiazepines in patients in advanced cancer and COPD. The studies just aren't there, they're small, they're not designed for effectiveness. So we just don't have that evidence. However, there is evidence that buspirone does not help people with advanced cancer and breathlessness. The randomized controlled trial was sufficiently powered to discard the null hypothesis, but the null hypothesis was upheld. There was no difference. And likewise, a sufficiently powered phase 3 placebo-controlled trial of sertraline found evidence of no benefit. As I said, the randomized controlled trial of mirtazapine versus placebo is ongoing at the moment. I just off a call yesterday with the study team, and we will await the outcome of that with interest. So in summary, for chronic breathlessness, the breathing, thinking, functioning model is useful for management. Evidence-based non-drug and drug interventions can modulate the perception of breathlessness and help people to live better with it. Immediate release opioids are limited in evidence and possibly less safe in acute or chronic breathlessness. I think that we need to become very cautious with use of immediate release opioids for breathlessness. Cognitive approaches, so utilizing the power of the mind, if you like, can modify the emotional response to breathlessness. Exercise and other ways to maximize function are important. In the future, we need longer-term data on morphine. The Janssen trial is the first to give us several weeks data. Other opioids need to be studied, other drugs need to be studied, and service models which incorporate breathlessness interventions are very much needed, because all of us can incorporate a lot of these techniques into our daily practice, but having specific breathlessness services for those with persistent and really complicated breathlessness is invaluable. So that concludes my chronic breathlessness section, and then I'm just going to talk a little bit about chronic cough. And I want to recommend to you the European Respiratory Journal publication of the European Respiratory Society guidelines for chronic cough, headed by Alain Maurice, who works also at University of Hull. Caused by hypersensitivity of the vagal afferents caused by epithelial damage. So epithelial damage from the disease itself with inflammation, smoke pollution, and gaseous non-acid reflux. So just to pick up that last point of gaseous non-acid reflux, it's not acid reflux as we know. It's not actually the acid. It's like it's almost like a gaseous cloud of acid that seems to be very irritant. And so therefore, PPIs are not effective. They're no better than placebo for chronic cough associated with respiratory disease. PPIs don't treat the reflux, they only block the acid, not the gaseous mist. So what might help? Well, again, non-pharmacological measures seem to be helpful. And so cough suppression therapy by trained therapists. And for that, again, I would refer you to this paper if you want to read more. In terms of pharmacological interventions, I think azithromycin is something which is important. Using it as a motilin agonist, so not in terms of its antibiotic properties, but in terms of its promotility, it can be effective in addressing that gaseous mist. And of course, it is also a cheap option for when that is an issue. Metoclopramide and domperidone also act as prokinetics and increase the tone in the lower esophageal sphincter. And of course, 75% of patients with chronic cough have demonstrable esophageal dysmotility. And particularly people with interstitial lung disease, we know it's a particular issue. Low-dose morphine, again, Alain Maurice's trial, several decades ago now, of 10 BD of sustained release morphine works in about a third of patients, as recommended in guidelines. And hot off the press, paper just published by Alain's team in the Lancet last week. Epithelial damage is also known to release chemical signals called alarmins, particularly ATP, which then act on the P2X3 receptor. And they have an antagonist. And I don't know how to pronounce this. I'm going to call it gefapixant, but your guess is as good as mine. And this appears to be more effective than placebo in reducing the amount of coughing. It doesn't wipe it out, but it might ease some people. And it represents the first new treatment for cough in decades. So that's the Lancet paper, McGarvey et al. Out last week. So hot off the press. So that concludes my talk, and I'm happy to to answer questions, and I believe there's a case study that we can work through. And I leave you with another picture from our breathlessness exhibition. This is depicting one patient who used to love gardening and who says now that she just feels smothered by her breathlessness, and it has robbed her from her pleasure in the garden. And it just puts in pictures the experience of one person living with breathlessness and reminds us of why we cannot ignore this symptom and allow it to remain invisible. So thank you. And I'll stop sharing my slides now and go back to Sri Devi.
Thank you, Professor Miriam. I think that was an excellent talk, starting from the gap between identifying breathlessness. People don't express themselves when they are breathless, and then very good idea about the non-pharmacological management, which we really don't focus at all. I must admit, because although we have read through all this evidence, I'm sure many of us don't actually put it into practice. Still people, as you mentioned, people are scared about thinking about cool air onto their face because it's supposed to increase your breathlessness, increase distress. People tend to switch off the fans in the room still, thinking that the patient might be breathless, and the patient themselves feel that the fans can actually exaggerate their breathlessness. So thank you so much for taking us through that journey, starting from the gaps and the non-pharmacological part, which I think it's high time that we start focusing on the non-pharmacological methods of controlling breathlessness. So we have a few questions coming up in the chat. I'll just, is there any evidence for nebulized furosemide for chronic refractory breathlessness?
So there is some emerging evidence. And in fact, in one of the slides, I referenced a paper by Carlo Barbetta, who has summarized a lot of the non-opioid drug evidence, and the papers that you want are in there. So they are included. They are very early stage studies at the moment, and the difficulty is that when it's been done in heart failure, it's difficult to know whether is this because you're getting systemic absorption of a diuretic and the diuretic is then helping, or is it doing something directly? There is some evidence to suggest it does do something directly in terms of smooth muscle relaxation, and perhaps some bronchodilation, but that then would only work if there was bronchoconstriction. So that it's very much work that's ongoing, and it's a bit of a palaver to do, and if it benefits, it's probably only going to give some very short-term benefit. However, there is a very interesting study, randomized control trial study done by someone whose name has just escaped me, and I will send it to Sri Devi afterwards, where they randomized people with COPD to have saline, normal saline, nebulized through an efficient nebulizer, or randomized to a nebulizer that had basically was a rubbish nebulizer. So there was no deposition of saline anywhere useful. And what they found was, firstly, sputum clearance was better in the nebulized saline, but also breathlessness was better in the nebulized saline. Now, whether that's due to cold stimulation of the airways, or it's because it's helped mucus clearance, or because whether it has some direct effect, I don't know. But I would certainly say that nebulized saline is something which is simple to do and is unlikely to do any harm, and can be repeated whenever people like. The other thing, there's some emerging work about some nebulized menthol. There's at least one study now in the European Respiratory Journal using menthol, inhaled menthol. Now that does have a good physiologic basis as a TRP receptor agonist. And I would say certainly, I don't know if you have, we have this sort of cough lozenge called Fisherman's Friends. Seeing some nodding, Rada is nodding, thank you. I mean, they smell disgusting, but they've got menthol in them. And certainly some patients talk about inhaling menthol crystals, steam inhalations. And there's good rationale why menthol should help as well. Exactly where the role of this is or how we should do it is all very emerging at the moment. So, and I didn't have time to go through all that in the presentation. So thank you for that question. There are other little bits and pieces. Shall I have a look at the next question then, Sridevi?
Yes, yes. So the next question is specifically
So your
on
next, yes, well, and this is where I think I will leave the Pallium Indian people to talk about authorization for prescribing morphine, because I know you do have a whole series of hoops and hurdles to go through. So you might like to take that question.
Yes, I think Dr. Rajni or Rajan, would you like to quickly answer that question regarding the authorization of morphine, or else I can just answer that.
So as a pulmonologist, if I am in an institution which is a registered medical institution for prescribing morphine, where the pharmacy in our institution can prescribe morphine, as a pulmonologist, there's no problem for me to prescribe morphine and have our pharmacy dispense it. I think it's only if so as a specialist practitioner for that indication, when we give it in the doses as described, I've not faced any trouble with it. So even if my patient has to go to another center, if it's not available at our hospital, if they go to another RMI pharmacy, which is licensed to dispense morphine, they can get it with our prescription.
So it's a question of whether the institution for which you work has a license to dispense morphine or not.
To dispense morphine, yeah. So
is there any training that's required?
We work off the institutional license. Okay. So specific training for morphine is just about, specifically for breathlessness for this indication, is to just make sure that the prescription is done in the way that we prescribe opioids, with doses, tablets, number of tablets, the patient's name, the patient's address, all the licensure. So it's a very, it's a far more detailed prescription. But beyond that, unlike how the amount of hoops one has to jump through for prescribing morphine for pain, which is in much higher doses, for breathlessness, it's not that difficult.
I only, if with the, sorry, Dr. Miriam, if only with permission for everybody, I just want to add, the problem comes when you have a patient who is being seen at home largely, and what the issues we had during the pandemic, when we couldn't see patients regularly and patients couldn't come to the hospital. So we have noticed the issues which even in an urban place like Bombay is availability and accessibility to morphine. So prescription writing is one issue where, yes, family physicians trained in palliative care can only write the prescriptions. Like Rajni said, any registered medical institute, if you have a particular person under whose name you can procure morphine, and the pharmacist therefore maintains a detailed log. The problem comes with private practitioners. The problem comes with family physicians whose prescriptions may not be honored by all chemists. So that is one issue we face commonly, and therefore to rope in a palliative care physician or a physician trained in palliative care helps, because we have to give a triplicate prescription. We have to write out the number of medications. Now in breathlessness, because we start on a low dose, and unfortunately in India, because we do not have sustained release, it becomes immediate release. So we have to be very careful of how we are writing the prescription, because if you write 2.5 milligrams, which is what we start with, the chemist is not going to give you that, because he has only a 10 milligram strip. So you need to write 3 sets of prescriptions for the patient, for the chemist, saying 10 milligrams, say twice a day for 15 days, therefore these many tablets, and sign on all 3, no carbon copies, with a stamp. But on the patient's pad, you have to be very clear and say, I am starting with 2.5, and this is, so you break the tablet into 4, and this is how you give, etc. And make a note of how much SOS you give, and therefore come back to me in 15 days. And it's unlikely that your patient with a 10 milligram tablet finishes his course in 15 days. So you also need to be vigilant on which patient you have prescribed how many times, because if they're obviously coming back to you often, there is some mismatch there, and you need to be alert, because finally it's your signature and your letterhead, and we need to be responsible and not go the American way where it is getting abused and there's no accountability. The other thing that we face is when patients die at home with available morphine. So very clearly, when we dispense these medications, I clearly say you need to flush this morphine down the toilet after the death of your patient, because in their confusion, in their rituals, in their grief, they might forget that, and we cannot afford morphine lying loosely in the house, because most of our patients do have hired caregivers like ward boys, aya bais, etc. And we don't want it to go in the wrong hand. So these are the small practical issues we have faced. In an institution, please, getting a morphine license is not difficult. Pallium India will give you a detailed way of how to get RMI license. But what we face in practical is these small things which you need to be cognizant of, and therefore team up with a palliative care group in your city or your suburb, and it will be much more easy for you. Thanks.
That's really helpful. Thank you. And can I just say that, I want to emphasize that the main benefit you will have will be with the non-pharmacological. You will get a very small additional benefit in some people with morphine. The prescription is not the answer to this main issue. It's about modulating that central perception by working on these 3 vicious cycles that wind up the breathlessness. So it is part of the toolbox, if you like, but it is a very small part of the toolbox. And I would say that if you can't get access for whatever reason, that is not going to seriously damage your management of these patients. What will damage them if you don't implement the things that all of us can do, because we can all speak, we can all use our hands, and we can sort out a lot of these other things without any particular additional outlay or fancy high-tech equipment or kit. And that is where I think the majority of effort should go into. I'll just shall I pick up the next question?
Yes, please. Yes, please.
What preparations are available for morphine? Well, I think actually, Rajam, you've addressed that. I know there are some, like I know in some places you can get fentanyls, you can get buprenorphine, you can get a range of things, but in many places you can't. I think the message is use low doses and put them in as regular. This is not for PRN medication. It's very different to pain. It's you manage the acute breathlessness episodes by bringing them back down with non-pharmacological breathing, getting back in control of their breathing, not by popping another pill. And that's a very different approach, I think, to the way we approach often pain medication.
And just to add, we don't have oxycodone and hydromorphine in this country at all. So we only have morphine sulfate, which is available. And even in Mumbai, we have only immediate release. I'm not sure of sustained release. I think is available in Delhi. I'm not sure. Is it, Sridevi?
Yes, it is available at some places.
Yeah.
Even in Kerala, we have.
Yeah,
right.
and in Bengaluru, I know they can get some sustained release and fentanyl as well.
Some sustained release we do get in Bangalore as well as in Telangana. So folks from Hyderabad can.
So it's very variable, I think.
It's state to state.
Yeah.
It's much more easily available in the southern states. And again, the other thing is, as Dr. Rajam Iyer mentioned about making friends with the palliative care physicians, the network in your city. The other place if you're in a large institution that usually has permission and has access to it, is your oncology daycare center. So I know a bunch of hospitals in Bangalore where pulmonologists access the morphine for their patients, and their patients wonder why they're being sent to the daycare oncology center, but they're being sent there for their breathlessness meds. So that's another place to get.
Communication is important. I remember the first patient with heart failure I saw, and they were convinced it was a covert message that they had cancer, and no one had the grace to tell them. So they were sat there looking like a frightened rabbit.
To pick up their meds at the daycare oncology.
So here's a nice question here. So this is from Kiran Vishnu. Are we allowed to start opioids at the time when we anticipate a protracted course of suboptimal responses, as in an IPF patient? I would say I would always start with the non-pharmacological interventions and see how you go. And it's really when you're getting down to breathlessness pretty much at rest or minimal exertion, I would be thinking in terms of adding in opioids. But all the non-pharmacological stuff, start right at the very beginning on first diagnosis. Teach them some techniques to be able to manage their breathlessness, and don't hold back with that. Not clear yet on the mode of. Oh, here's another good one. Sorry, HEMA KR. Afraid I don't know what your KR stands for. I'm not clear about the mode of action of morphine. Acts on all. I think you could argue it acts on all. So it certainly acts at the central level. So if you remember back to the functional MRI study showing that it seems to reduce that level of psychological priors of those anticipated sensations at the cortical level, it seems to reduce that, sort of filter it through and dampen it down a little bit, not quite so distressing. But if that allows you to move more, that is then going to help you with your functioning spiral, because it might help you with your reconditioning. And if you're not breathing quite so rapidly, that might help with your breathing function. And if you're starting to feel a bit more control of what's going on, it might help your thinking function. So although we've got our 3 different cycles, we do recognize that's somewhat of an artificial separation, because we're not different cycles. We're just one big mess, aren't we, really? And what affects one bit goes into the next bit. So I think that's a brilliant question, because I think it is, you know, I tend to think of it as very central as its effect, but actually I think you can argue it having indirect effects at least further round. So then there's some comments about different availability. That's lovely. Saw a patient referred for breathlessness today. ILD, no one referred for pulmonary rehab yet. I mean, isn't that sad? You know, and it is such a sad commentary that this still happens. Physiotherapy with pulmonary rehab. And it's not just you. I mean, the UK is also in a big mess over this, and trying to get people to pulmonary rehab, particularly with ILD, where it has not been standard. It's only recently coming through that this is the thing to do. It's been focused on COPD, and yet the ILD people. There's an interesting study, actually, while I'm thinking about it, that not all of the pharmacological techniques might be good for all types of respiratory difficulties. So, for example, there's a lovely paper showing that pursed lip expiration actually wasn't particularly helpful for people with ILD. And that makes sense, doesn't it? Because if you've got a lot of fibrosis, you're not going to be able to increase your end expiratory pulmonary pressures by pursed lip respiration. So that also confirms to me that there's probably some useful mechanism in the pursed lip respiration in the COPD people where they can. So again, that underlines to me that the non-pharmacological does not mean non-biological. There is a physiological basis for these interventions, and we just need to be smarter at using them instead of being, if I can be really, as a doctor, I can say this, lazy in running for the prescription pad, rather than doing perhaps something that will equip our patients more effectively for when we are not there. That was a bit of a rant, sorry about that.
I just wanted to make a point here. When you say that patients are not referred to pulmonary rehab, even in England, the point is in England, they do go through an NHS, which is provided for them. So I think it does tend to have a backlog. What saddens here is patients are ready to pay. They are affording, and 80% of India go through private practice. Even in patients who pay, I'm sure if we tell 100% of our patients, maybe 50 will hear and 30 will go. Point is that we need to do our bit. And that is what is important, because patients pay, and some of the patients, if they're convinced about how physiotherapy can actually help them improve quality of life, I can't see people saying, I will not go there and I will continue to just pop in pills. So it's also our onus to emphasize the need for of being there for patients to focus on non-pharmacological interventions. It really does make a difference. We see this at home, even with elderly in the house. If they're more active, they remain more happy and they remain, more healthy. So I think it's something that we really need to emphasize in our teaching.
And I think a doctor's word goes a long way. And we
Absolutely.
can argue until we're blue in the face that shouldn't be the case, that we have skills, the nurses have skills, the physios have skills, but the patients will still listen to us when perhaps they afford us more credit than we deserve. But they will listen to us. And if we do not strongly recommend, endorse, underwrite it and say, this is just as important as your inhaler, you must go and you must try and keep doing that. They are very, it's hard, isn't it? Pulmonary rehab is hard. You're asking for lifestyle changes. You're asking them to go and do something which is going to cause the very symptom which they are trying to avoid. So I think, we have a really important role with that. Another lovely comment here. Physiotherapists for pulmonary rehab can do online pulmonary rehab. Absolutely. So, sometimes these things can be found. You can point them in good resources. Do a little bit of Googling one night, a bit of light Googling, and find some sites that you could recommend to your patients if they're wanting to have a little look, see what it might mean. Pursed lip taught as mindfulness to help anxiety, helping with the thinking. Yep, I'm glad you've mentioned mindfulness. We've just caught on to mindfulness in the UK. You know, we're a bit slow on the uptake with these things, but, you know, we're getting in touch with our inner mindfulness. I would say a little word of caution in that the full, certainly over the way it's taught over here, is it's a full-blown 8-week kind of fairly intense course. You're going to have to modify it for some of these really poorly breathless people, you know, trying to get through all that lot, you know, really. And the other thing I would watch for is if your mindfulness has too much attention to breath, which mindfulness often does, you can actually make your breathlessness worse. Because you're focusing on the very thing that they're trying hard to avoid. So I would just say with mindfulness comes with a little bit of a health warning, modify it for our patients and just try to take the focus off the breathing. What you could do is to get them focus on that, you know, use it with airflow. Instead of focus on their in-breath and their out-breath, why not focus on the sensation of the airflow going across their face? And enjoying that in the now might be one of the ways to do that. Gosh, these questions are coming in thick and fast. This is good. Shows you're all awake. It's very good. All awake and kicking late in the evening. For you, that is. I'm fine. This is lovely. Most international things I do means hideous o'clock. And you're so lovely, only being 5.5 hours ahead. Thank you. So can we prescribe breathlessness? So in type 2 respiratory failure, I would say with this, you start with a low dose and you monitor. Morphine becomes a problem is if you go in too high, and it's it depends on degree of type 2 respiratory failure, isn't it? And if it's mild and you're going to keep an eye on them, I don't think it's a problem. But if you give them a dose and you send them away and you never see them again, they might die on you. So it's the same with all of these things. You make a change in management and then you monitor it very, very carefully. And if you've got someone in severe type 2 respiratory failure, then you might just want to, maybe that's not going to be the drug for them. An old lady known episode, help with headphones to watch her TV program. Yes, you know, and isn't that a brilliant example? So watching headphones to watch her TV program, that's about the functioning circle of reducing her social isolation and reducing her ability to enjoy life. And again, it's about this focusing, a sensory focus on something pleasant rather than the unpleasant breathlessness that's going on. What I would do though is tell her to hide the remote control. So she has to get out of her chair to change the panel, the channel. Or I say to my patients, I want you to do something every hour that makes you breathless. I do not want you growing roots in the chair. And teaching them the sit to stand exercise. Non-pharma BiPAP patients continue to be breathless. Yeah, and I think, so this is about, yes, I've done everything. And I think where this is, you really are running out of options, and I think that is when you could think about trying low dose opioids. And I would also say, you have a very clear idea with the patient as to what a meaningful improvement is, because not everybody does. And you do not want to keep them on it because it makes you feel better because you've done something. Treating yourself and subjecting the patient to harms of constipation, of potential confusion, is not a good look for a clinician. You know, we should not be treating ourselves. We need to treat the patient, but try it, but have a very clear clinical review and a decision as to whether this has helped. If it has, keep them on it. If it hasn't, stop it. And if they haven't shown any signs of any improvement in anything in a week, if they are tolerating the dose you started, then you might like to go up to the next dose, but I wouldn't go more than 30 milligrams a day. And I wouldn't titrate up more quicker than once a week. I think if you racket this up, you're going to hit problems. And also our study looking at improvements after a dose increment, it can take about a week to get maximum benefit from it. Sensory awareness, mindfulness, yeah, see lots of really good stuff coming through here. Any links to get good physio online for rehab, I'm going to pass that over to the Pallium India team, as you will know that stuff that's relevant for you.
We have to, as you mentioned, Google it.
Most of the good hospitals in the country have a good physio, and big thanks to the pandemic, most of them are doing online. So for example, the hospitals I work, Bhatia, Hinduja, they're all doing it online. So most of the big, I'm sure even the Apollos and all of them do. So thanks to the pandemic, I think this has changed for sure, availability. And the best thing about this online is it can actually be done suited to the timing of the patient. So which time of the day is best for him, and he doesn't have to really go to the hospital. So all those logistics are taken care of. So most of the big hospitals do online physio. And one last point I would like to add is about terminal breathlessness, which we see, especially if goals of care are discussed and decided by the patient and the family, and we know ICU is not an option, though palliative care can be done in the ICU, which are coming in the next few sessions. The importance is how to control the breathlessness at the end, which could be due to anything. It could be due to CKD, it could be due to CCF, it could be to advanced cancer. That time, the role of subcutaneous low dose morphine with or without midazolam and haloperidol really does work. And me and Dr. Sujit have looked after patients actively dying with IPF. With this subcutaneous infusion, it does work because everything else is not possible to do with a patient who's actively dying. So that's a note which is interesting to work, because we are really at our wits' end of how to keep this patient comfortable, not just for the patient's dignity, but also the caregivers, because the caregiver's discomfort is directly related to how comfortable or uncomfortable the patient is. So sometimes caregivers require much more hand-holding and support, and naturally so, expectedly so, it's very hard to lose your loved one, and especially when you're not doing all the aggressive routine stuff. So I think this kind of discussion and goals of care discussion and advanced planning is extremely important in your patients with IPF, with COPD, because unfortunately we cannot offer them any cure. So it's very vital, and it's very satisfying to see a patient transition comfortably, especially with conditions like IPF and COPD. It's very, very satisfying to see these patients die in peace. It's also very good for the relatives to have a relatively less turbulent bereavement phase.
I think that's a good point. No, that's a great point, Raja, because what I've been talking about has been the ambulant patient. I've not been talking about the patients in the last hours, days.
Which will be taken up in end of life, but I thought as a part of breathlessness,
absolutely
needs to be emphasized.
And the challenge is that the only difficulty we have in those very last stages, we have very little evidence to support what we do. But communication is incredibly important, and explaining that what you're doing is basically you're sedating somebody while they die. You are not sedating them to die. If you see what I mean, there's a distinction between that there, and that's basically what you end up having to do, is that you are sedating somebody so they are less aware of their distress as they die with their advanced and end-stage disease. So that's a good point. Thank you.
Medical legally, we would say intent is comfort. Intent is not to end life. It is really the intent is comfort. And like Dr. Johnson said, the most important thing is to communicate that we are giving this not to end life, but the intent is comfort.
Thank you. Thank you so much for the wonderful discussion and the questions from the participants. Shall we move on to the case presentation by Dr. Kiran? Dr. Kiran, over to you.
Good evening, respected faculty members of Pallium India, guest of honor, Professor Johnson, and my dear friends. I'm just speaking about a real life situation I recently encountered. This is a 34-year-old female whose initial diagnosis we kept was bilateral fibrocavitary disease with a lot of mycotomas. She was in respiratory failure, and her functional status was around ECOG 3. So going to the complaints, when I first saw her around 8 months back, she was having progressive cough with expectoration and shortness of breath for the last 15 years. She was occasionally coughing out blood, and sometimes the episodes would be massive episodes of blood in the phlegm. She was having appetite loss, and her parents were saying that she was having no weight gain for the last many years. So, non-consanguineous parents, she had an uneventful childhood. After her 10th standard, she remembers that most of her time in and out of hospitals with recurrent episodes of cough and phlegm. So, and she would have these bouts of coughing out blood, and she would require to be admitted in hospitals with long days isolation. There was an unending cough and a strangulating breathlessness. So when I saw her 8 months back, she had just recovered from the second wave of COVID. She was too breathless to even talk. She had a sunken eyes and a feeling of helplessness. So the consensus diagnosis was bronchiectasis, probably post-tubercular. We do not know whether it was really a sputum-positive pulmonary tuberculosis and post-tuberculosis sequelae resulting in mycetomas. So she had received multiple courses of anti-tuberculous drugs on a presumed diagnosis of clinically diagnosed pulmonary tuberculosis, multiple courses of antibiotics because of a phlegm and blood being spit out. And she was unluckily puffing repeatedly on her inhalers, on the salbutamol inhalers to catch her breath. She was on supplemental oxygen, and we were trying to keep her oxygen levels above 92%. So on examination, she was pale, cyanosed, she had clubbed fingers, there was spitting, bilateral pedal edema. She was propped up, she couldn't even talk because of her breathlessness. She was tachypneic and all the accessory muscles of respiration were active. She was emaciated with a body mass index of just 16. She was tachycardic, hemodynamically stable, and saturation on room air was just around 78%, which improved to 92 on 6 liters of supplemental oxygen. Chest examination showed bilateral coarse crackles and wheezes with conducted sounds. The jugular venous pressure was elevated, and there was a doubtful clinical feature of pulmonary hypertension. There was no organomegaly or focal neurological deficit. So on investigations, she had anemia, microscopic hypochromic anemia. There was a polymorphonuclear leukocytosis. The sugars were normal. She was having hypoalbuminemia. The renal functions were normal. Urine showed no evidence of any pyuria or deposits. The cascade of phlegm investigations we do for a bronchiectasis patients were done. So we did investigations, PCR test for Mycobacterium tuberculosis, which is not detected. The gram stain in culture revealed Klebsiella. The fungal smear, because of the huge mycetomas we were seeing on the radiology films, but as it turned out to be negative. And this is the axial radiology CT cuts of that patient. Apologize, I couldn't shadow the name. And you can see bilateral extensive fibrocavitary disease with involvement predominantly on the right side and some involvement on the left side also. And huge, I do not know if I can describe it, looks like fetus is lying in within the cavity. So they were actually huge fungal balls. And coming to the psychosocial aspect, she was married, but she was living with her parents and her 2 siblings. Her husband had disowned, and her only earning member was her father, who worked in a roadside eatery. And they could not afford oxygen at home. There was a poor nutritional status, obviously due to the poor living conditions. Her respiratory status wise, she had extensive lung disease and she was incapacitated. There was a lot of social isolation. She was depressed and worried that she was a burden for the family. And she was really fed up with these hospital visits. So dwelling into the case, and we thought the diagnosis of chronic cavitary fibrotic pulmonary aspergillosis. So whenever she had OP visits, we would give her at least broad spectrum antibiotics for the cough and purulence. We gave her antifungals considering the diagnosis of chronic cavitary aspergillosis. We gave her bronchodilators with spacers. We gave supplemental iron, folic acid, and B12. We managed to give her an advice to take 2 eggs a day and milk with balanced diet. And as Miriam taught us, we also had given her rehabilitation. So we taught her what we could give maximally. And there was a good therapeutic response. In fact, the CT that is taken is around 2 months back. There was an obvious reduction in the radiological shadows, at least. But the lady was the same breathless lady. She couldn't even walk to see us in the OP room. But we had to reinforce her and her parents that she would get better with the drugs. We continued with the same old drugs, nutrition and inhalers and exercise. But palliative drugs to relieve her helplessness did not come to my mind, honestly. And unfortunately, she left us a month back. To summarize, we have a young female with extensive lung involvement, which I believed I had successfully diagnosed and treated. And from the patient's perspective and the family side, I had actually failed in reducing her distress or providing solace to her parents. And by the end of the day, I think it's all about patient satisfaction and relieving their anxiety when they look upon us. So I think the points to be discussed would be, I think, should I discuss? Ma'am would take over. Thank you. Thank you for the opportunity.
Thank you so much, Dr. Kiran. That was a wonderful, wonderful presentation, and how much you are involved in. I think you can keep the questions on the screen so that we can just,
Right.
and how much you have got involved, and at least you reflected back after she passed away, like what that's the first. I really respect that. Yeah.
Thank you.
Yes. Over to the experts in the group. Yes, definitely.
And I would have to say that I think there is a lot of expertise amongst us, and I will be calling on those who have expertise with this. So, you know, those of you I know as Rajam and Rajnees, I don't think you're off the hook here, and other people who I'm sure would have wisdom to add. But firstly, I would like to acknowledge your honesty, and I think you have really put the nail on the head of how distressing this is for clinicians, that helplessness. And I think this is such a really good case to bring, and how you can find radiological improvement, but still symptomatically people seem to be stuck. And you know, we may have helped some aspects, but we haven't actually helped the patient overall, and we can be left feeling really uncomfortable about that. And I think being able to recognize and own that is very impressive. And thank you for saying that, because a lot of doctors don't, and they then retreat behind their little walls, and then they don't even address the issue at all next time. So I think that's been done very well. I just had some some questions in terms of, and again, this is where others please jump in. I wonder what her understanding of her situation was, and how easy that might have been to have had that conversation, and also not her understanding, but also her family's understanding, to try and get at what's important for her. And what's important for her would be in the context of what she understands is possible. So if she's thinking I can get back to full health, then she may miss other things that are very important, like she might want some time at home, even if that means she can't have the oxygen therapy, and how would that manage? I want to be able to spend some time with my siblings, or I want to be able to have some conversation with so-and-so. You know, those are things that actually can be achieved, but they won't be achieved if they're overlooked. So if somebody is thinking, I'm here and I'm going to do that, and then they're going to be very frustrated and feed into the anxiety and distress of the situation. Whereas that conversation of what does she understand? Can we move her to a realistic understanding and expectation and goals? And I don't know, Kiran, you'll be better, you know, you're the one who knew her, walked through this with her. Is that something you thought of, or could you have got near?
Yes, Miriam. I think basically she wanted to move around. She wanted to be with her siblings. During the last few weeks when she visited us, she wanted to at least move to the bathroom because she was so much incapacitated. And I think she wanted to see her husband also. She was still attached to her husband. Yeah.
So you see, those are goals that you've identified, and it sounds to me like you help facilitate at least some of them.
Yes.
And so sometimes I think as clinicians, we're a little bit hard on ourselves, and it sounds like you've actually helped her achieve some of the things she wanted to do, and by letting her go home as well. Is that right? Did I pick up that right? She went home, even though they couldn't afford the oxygen. Yeah, and that is a very patient-centered, a very person-centered approach. And I've seen certainly sad situations where the patient has been desperate to get home, but they can't have such and such a treatment, and they've been told you can't go home without it. And I'm thinking, well, why can't they? If that's so important to them, it's about weighing up what's important to the patient and doing that. I mean, Rajam, do you want to comment on that aspect of things?
I think I just want to add that this is exactly the journey that I have noticed in the transformation from a pulmonologist to a pulmonologist trained in palliative care. And that has come out beautifully in this. I know how I was 5 years ago, and I used to probably not delve into all these issues. And these points that have been discussed today, and thanks to you, Kiran, for the case, has come out beautifully. The fact that if we can feel so helpless and so distressed with what the patient is experiencing, imagine what the patient and the family are going through. And this is a patient of a lower socioeconomic, which means money is an issue, survival is an issue. She's had a broken relationship, so many things going on. And, we are trying very hard to fix the lung when so many other things are going, completely array for this patient. So I think what has been shared by Professor Miriam is this person that we need to look out for and be there and help in whatever way. And I think I keep reiterating myself so that I don't end up being dejected, is that you can't change everything, but you need to try. And that's very important so that you also can go and have a good night's rest, because you don't have a magic wand to wish away all the patient's problems. But what satisfies you is that you addressed it, acknowledged it, and was there for the patient to offer support. And that is the biggest learning that we can take for transforming yourself from only being a pulmonologist to a pulmonologist who is trained in palliative care. I think that's what I want to say. Otherwise, this is exactly what my journey was in the past 5 years. And I'm glad that there are going to be all of you now joining us. So thank you very much for that.
I'd like to say, Dr. Kiran, I'm going to add my thanks and gratitude to you for sharing this. It's so evident how deeply, how much care and attention you gave to this patient. She still is in your mind. We can see that in the way you presented. And I'm also thinking of the fact that today is World Tuberculosis Day, and the patient whose story you shared with us is a story that we see so much of in our practice. It's, they may have suffered tuberculosis at some point in their life, but they are left with structural lung damage, lung disease, which is going to affect them for the rest of their lives. The suffering that you described in her life, if we looked at it from the lens of total pain, there were so many dimensions to her suffering, and so many issues that we needed to address. We've spoken about palliative care for pulmonary diseases. Palliative care for patients with tuberculosis and sequelae of tuberculosis remains a highly under-addressed issue in our country. There are very few countries which have well-structured programs for palliative care for patients with tuberculosis. So that's just another thought that I want to leave there, that this is something that we need to address proactively in our patients with tuberculosis. What are the things that it from?
And I wonder if I could just add something, just thinking in terms of this particular patient, if you're thinking, would I have done anything different? I always have this sort of little thing I follow through in my mind. I think, right, okay, reverse the reversible and palliate the irreversible. And I think you've demonstrated really well how you've looked to see what are the potentially reversible issues here, and you've addressed them, absolutely. And that is just as much part of palliative care as palliating the irreversible. The only thing I would add to the reversible is always have a view to when do you stop. So what is your measure for success? So for example, I remember vividly seeing a patient with the consultant cardiologist, a lovely old guy with end-stage heart failure whose temperature chart looked like the Himalayas. So the consultant, this is a patient who'd wanted to die in the hospice. He was very end stage. And he'd been there for 10 days with this temperature chart going up and down like this. And I said, can we get him over to the hospice? And the consultant said, well, he's still on vancomycin and they won't be able to give it to him there because it was through a central line and whatever number of reasons. And I said, well, if you were going to reverse the reversible, when would you expect to see that being reversed? Or are you going to carry on trying to reverse the reversible until he's dead? And so when you start something, I would always have an idea of, if this is going to be reversible, when would I start to see an improvement by when? And what improvement would I be convinced about by when? So for example, if I've got someone who's dehydrated and I think the dehydration might be contributing to they might be dying, I say to the family, right, I'm going to give them a trial of fluids. If this is having a material benefit, I would expect them to be sat up and having breakfast by, whenever. So that you have, if this is going to do something, it's going to do this by then. And as a respiratory physician, you will know way better than me what you would expect to see in terms of improvement. So I was just saying, have a very clear idea of what you'd be expecting to see and be prepared to say, no, this is not working. I'm now going to stop that. Because it's got cost issues for the patients. It's got burden of treatment issues for the patients. So that's one thing. The only other thing I wondered about in terms of the cough and the repeated cough, would she be worth a trial of keeping her on something like azithromycin, just in the hope of trying to reduce that? But again, it would be, I would give it for a couple of weeks. And if it hasn't materially reduced the coughing bouts, I would stop it so that there's not that additional burden of treatments. So those are the things that I was mainly thinking about. And in the palliation, yes, depending on, when she was, depending on what her goals were and what level of consciousness she wants to be as she gets more and more poorly, staying with her and thinking, well, do we now need to use some drugs to help reduce levels of stress and awareness at that stage? That's something for the future. So those are my two additional things, is that reversing the reversible, palliating the irreversible, but learning to distinguish when one has become the other is really hard. It's easier to start something than it is to stop. So having an idea right at the very beginning, I'm going to give this for X period of days, and then I am expecting to see this amount of improvement in this parameter. And if you don't, having that courage to have that conversation and say, look, if this was going to work, it would have done this by now, and it hasn't. So I don't know if that's a time-tested trial. Thank you, Miriam. That was a bit of a long-winded say of saying time-tested trial.
Going back to your discussion points, definitely psychological counseling would have helped her. Maybe you could have spoken to the husband and got him. I mean, if you, like Miriam said, sometimes doctors' words actually have a lot of weightage. So if you had messaged him or called him up, or not you, as in your team, saying your wife is not doing well, maybe he would have come and she would have had some kind of a closure. Hand-holding the family, because, when they're socioeconomically so poor, even grief becomes a very expensive commodity for them. They are supposed to pick up and move on with their lives. And it is very sad, because losing a child, burying a child can be most devastating for parents. And obviously, unfortunately, they can't take time off, because if they take time off, the rest of them will starve to death. So in India, I think that becomes very difficult for them. And therefore, I think preparing them for the loss of their child is very, very important. And there's another question, Professor, in his discussion points is, would opioids have drug interactions? I think better outcome is something we all want for our patients, but given the way she was, with the amount of damage that she had, I don't think that would have been any better. I think he has had a question about opioids and having drug interactions.
Yeah, I think the drug interactions, you just have to have a little look and see what they are. And then you make a value judgment as to whether the risk is worth the potential benefit. If you think the risk is worth the potential benefit, then you try low dose and you monitor and you watch and you stop if either there's no benefit or if you have any concerns. And I would also co-prescribe a laxative, because if someone's abdominal cavity is full of poo, if I can put the medical term on it, then their diaphragm's got nowhere to go. So I think that's, and the only other thing I would have a look at is to think about her raised JVP. There was a comment there about raised atrial pressures. You know,
Pulmonary
is it worth thinking about some spironolactone or a thiazide diuretic or something, just to shift if there's clinically significant peripheral edema that will be adding to breathlessness. Particularly, I'm thinking of ascites, again, because of diaphragmatic splinting, or peripheral edema in the legs. If you imagine it's hard enough to walk when you're breathless, if you're also carrying around 2 liters excess fluid in each leg, that's going to exacerbate things.
And I think that's also described beautifully by the doctrine of double effect, which is if you're actually giving a medication with the intent of comfort, then you know, kind of accept the fact that whatever it's going to, if the benefits are high, you accept the fact that it's going to complicate and probably even result in something like end of life, but it's in the best interest of the patient. The intent was comfort. So, you know, that is also another thing that you could apply. But I think every situation you weigh the benefits versus risk, and whether it is really going to help the patient and not cause more harm. And I think ethically and medically, then you will be doing the right things.
And it's worth having the ethics are an interesting one. I think probably for use of opioids at the end of life, I don't even think you need to invoke doctrine of double effect, because if you're using small doses, carefully monitored and carefully titrated, you should not be causing death. You may be, I think just that you've got to be a little bit careful with those low doses. I'm sure at times, Rajan, you know, the doctrine of double effect is very, very relevant. I would just have a little bit of caution in terms of opioids, simply because, again, it's so easily picked up and misinterpreted, isn't it, Rajan?
Yes, yes.
So, but you're absolutely right that in palliative care situations, you know, that doctrine does come into play. But I would say that with very low dose opioids, carefully monitored, we shouldn't have to bring that one in, I think. I would take a lot of care about that. And yeah, good question here about the family. Sorry.
If I may just interject over here for a second, it seems like this is a patient who came in for hospitalizations a few times. So especially when we see the decline happening, and we're seeing, you know, and we're going to discuss this in our future sessions about the surprise question. When do we start thinking about preparing the family to plan for things? So I'm just going to address that right here by saying that while they are in hospital, in one of those hospitalizations, is actually a good time to try out your low dose opioid and see, and then you can send them home safely, especially if it's a poor patient who's coming from a long distance and you don't want to give it as an outpatient and you're not able to monitor her. But a couple of times when she comes in for hospitalization for the IV antibiotics or the diuretics, at that time, if I can just get that one time to titrate the opioid, that's I try to take advantage of those inpatient moments for the titration as well.
Yeah, particularly with those very unstable patients. I think a good point about planning, you know, for someone who's coming back in and you can see that this is not going to go well, having that honest conversation and say, well, next time this happens, what do you want us to do? Do you want us to support you at home in the knowledge that we won't be able to do this, that, or the other? Or we could bring you in and try and do this, that, and the other. And we have, you know, very explicit conversations with people saying, well, you know, if you get another infection, do you want to try oral antibiotics at home, or do you want to come in for intravenous antibiotics? And then, you know, some patients say, well, look, you know, I'll give a go with tablets at home, but I'm really not coming back into hospital again. I know that means I'm not going to be able to have IV, but then I'll let nature take its course. And it's amazing, actually, surprising that many people actually will allow you to have quite explicit conversations, but it does mean that you have to do a bit of work up front. You can't just go diving in with your size 10 boots and say, you know, how about it if, oh dear, I had the most dreadful conversation once, you know, behind curtains in the ward, and someone had been sent in to find out someone's resuscitation status. And it was, well, if your heart stops, you want us to bring you around again? I'm thinking, that is not the conversation. I had to restrain myself from flinging back the curtains and saying, what did you say? I didn't. I thought I might frighten the junior doctor if I did that. So yes, we haven't talked about advanced care planning, but that I think is very pertinent in this situation. And I think you have a future session on that.
Thank you so much, everyone, for the wonderful discussion. And Dr. Kiran, I think going through the case presentation, it just still stays here. It will take some time to take it off the chest. But at this point, I would like to tell you that we have a wonderful team working in the medical college, the same institution that you work. So I'm hoping to have a better collaboration or more collaboration in future with your team. Thank you so much, everyone. Thank you so much, Professor Miriam, for the wonderful session and answering those questions. And I really like very few concepts that you were sharing. Thank you so much. And thank you so much, Dr. Kiran, for the wonderful case presentation.
Thank you so much.
Hope to see you all next week for another wonderful interactive session.